Perioperative Care by Samia Haddad. There are issues that arise for pediatric patients and their families undergoing surgery. Therefore, it is necessary for nurses to understand these issues and provide the appropriate care. This video will outline the important phases of perioperative procedure and the harmful risk it may have on patients and their families. This includes the risk of pediatric fasting prior to surgery, the patient going into theatre for induction of anesthesia, and post-anesthesia care. It will also discuss whether family-centered and atraumatic care methods can help reduce the negative impact associated with perioperative care. Surgery tends to evoke undesirable feelings and behaviors in children, such as guilt, avoidance, trust, and sadness. The perioperative procedure is an order of events which takes place before a surgical intervention is commenced. It comprises of three main phases: the preoperative phase, the intraoperative phase, and the postoperative phase. The usual preoperative phase starts when the patient is admitted having a surgical procedure until the individual is transferred to the operating theatre. The intraoperative phase is when the patient is moved to the operating room and goes on till the patient is admitted to the post-anesthesia care unit, PACU. Lastly, the post-operative phase commences with the admission of the patient to the PACU and ends up with the follow-up evaluation in the clinical setting. The phase that leads to surgery includes stress and emotional overload, with positive and negative consequences during and after surgery, involving phases such as the induction of anesthesia, the recovery period, and the post-operative period. Preoperative nursing involves a very important step, and this refers to the preoperative fasting, which each patient must undergo before entering the operating theatre. Patients are routinely required to fast before procedures that require sedation or general anesthesia. Anesthesia and sedation eliminate or reduce protective cough reflexes, unlike natural sleep. Therefore, the aspiration of stomach contents that are passively vomited or regurgitated into the oropharynx may be more likely during anesthesia or sedation. The reason for fasting preoperatively is to decrease the risk of pulmonary aspiration of the gastric contents. Fasting prevents the rise of gastric juices into the esophagus when the anesthetic is administered, which can lead to aspiration. Standard fasting time for children is usually around 6 hours for solids and 2 hours for clear fluids, which include water, cordial fruit juices without pulp, and ice popsicles. However, pediatric patients often stay for a prolonged period of preoperative fasting due to the normal sleep period before the procedure. Prolonged starvation can lead to other medical problems, including hypovolemia, confusion, hypoglycemia, headache, and irritability. Additionally, prolonged fasting can lead to thirst, anxiety, hunger, and discomfort. It is recommended for children to be allowed to drink close to surgery, which allow them to experience less hunger and thirst and anxiety. Furthermore, children who do drink close to surgery show better behavior and are more comfortable. Anesthesia induction is a stressful experience for pediatric patients and their families and their parents and may have potentially damaging consequences on their patient's mental and psychological mind. Anesthesia induction is a stressful part of surgery for pediatric patients and their parents. Children may experience mental, physical, and psychological distress due to anxiety at the time of induction. Stressful anesthesia induction has resulting adverse psychological impacts, can cause discomfort during recovery, and might cause regressive behavioral disorders. Nightmares, separation anxiety, eating disorders, and bedwetting have been reported as confirmed outcomes of anxiety among children. Children with high anxiety levels have a higher risk of expressing negative behaviors after surgery, and higher parental anxiety levels are directly associated with children's preoperative anxiety levels. Perioperative nurses observe that caring for children, mainly distressed or anxious young children, to be a challenging task. Parents can help ease any distress that the child may have, and it can assist with or indeed undertake distraction therapy. The main focus of family-centered care is making the parents involved in the child's care. According to the authors Hockenberry and Wilson, outline that there are three principles that provide a framework for providing atraumatic care. The first one is preventing or minimizing the patient's separation from the family. The second principle is to endorse a sense of control. And thirdly, is to decrease or avoid pain and body injury. It has been investigated that parental presence at anesthesia induction improves the children's anesthesia compliance and reduces children's anxiety. It is generally considered to be cost-effective, non-invasive, simple, and a way to help a smooth induction of pediatric anesthesia. Some of the advantages include increased cooperation of the child, enhanced parental satisfaction, decreased need for the perioperative medication, decreased distress and anxiety due to being separated from the parents. It has been outlined or investigated that perioperative sedative drugs are routinely recommended to manage anxiety of pediatric patients during surgeries. Many studies have recommended the use of oral midazolam for anxiety control in pediatric surgical patients. Other studies have stated that parental presence during induction of anesthesia not only has the same effect, but also has considerably better impact on the pediatric anxiety control compared to oral midazolam. Overall, the best method concluded that parental presence in addition to oral midazolam in pediatric patients can result in better cooperation at induction of anesthesia, decrease perioperative anxiety, and provides more satisfaction for parents. It has been stated that children may experience emergence delirium or agitation after anesthesia. Delirium or emergence is an undesired side effect and often is linked to inhalation of anesthetic agents and preoperative anxiety. Emergence delirium is defined as confusion state or motor agitation state happening anywhere between a few months from the emergence of anesthesia to up to 45 minutes. The child experiencing emergence delirium are often tilting and kicking, no eye contact with the individual surrounding them, holding their head backwards, involuntary movements, and inconsolable. Propofol is first choice when it comes to pharmacological prevention and treatment of emergent agitation. However, postoperative parental presence was considered the most beneficial. Also, parental visitation and presence in the PACU has proven to reassure and comfort the patient, decreases the need for pharmacological and physical restraint, and children cried less, assisted with child becoming oriented, decreases recovery time, facilitates accurate pain assessment, and enhances effective management. The risks of pediatric fasting prior to surgery, going to theatre for induction anesthesia and post anesthesia care are issues that arise for pediatric patients and the families when undergoing surgery. Family-centered and atraumatic care are particularly important in the operating theatre environment. Several types of interventions, such as pharmacological and physiological, can be used to reduce the negative responses of children and their families. Thank you for listening. These are my references. Thank you.